I would like to invite our next presenter, Dr.Randa Elgarhy. She's a teaching assistant at Pathology Department in Faculty of Medicine, Ancient University. Presentation entitled Smaller or Bigger. Dr. Randa, are you with us? You can start sharing your screen. Can you hear me?
Okay. Good afternoon, everyone, my dear professors and my dear colleagues. I am Randa Elgarhy, a teaching assistant of Pathology Department at Ain Shams University. I would like to thank Shifal Orman for organizing this event, and I would like to thank Dr. Riham and Dr. Muhammad Hussein for giving me the opportunity to present this mysterious case, smaller or bigger. So let's start with Sherlock, searching for the truth and collecting the evidences. A 23-year-old female patient presented with abdominal pain and discomfort. She had a history of nodular lymphocytic predominant Hodgkin's lymphoma, for which she received chemotherapy. She performed a PET CT scan showing pelvic-abdominal complex, partially cystic, partially solid adnexal neoplastic lesion. Also, it showed few abdominal lymph nodes and 2 hepatic focal lesions, raising the possibility of nodal and extranodal lymphomatous infiltrate based on the patient's history. However, they concluded that metastatic ovarian neoplasm is an indeterminate probability for better histopathological correlation. So, they sent us a true cut biopsy from the ovarian mass, showing a low power of fragmented tissue core, showing sheets of polygonal cells uniformly disposed with focal necrosis admixed with blue round cells. Extensive areas of necrosis can also be seen. In higher magnification, we can see rounded to oval cells with clearing of the cytoplasm. Some of them have pale eosinophilic cytoplasm with rounded to oval nuclei. Cystic-like spaces can be seen. Cells with prominent nucleoli can also be seen. These cells exhibit moderate to high degree of atypia with multiple mitotic figures with atypical forms, indicating a high-grade malignant neoplasm. So, Sherlock was in front of lots of suspects, including germ cell tumors as dysgerminoma, embryonal carcinoma, yolk sac tumor, 6-cord stromal tumors as granulosa cell tumor or polydifferentiated sertoli Leydig tumor, epithelial tumors as high-grade serous carcinoma, clear cell carcinoma, undifferentiated carcinoma, and the small cell carcinomas of hypercalcemic type or pulmonary type. Soft tissue tumors as rhabdomyosarcoma, desmoplastic small round cell tumor, others as lymphoma, Ewing sarcoma, and malignant melanoma. So, to solve this dilemma, a panel of immunohistochemical staining was done. LCA was negative except for the background lymphocytes, excluding lymphoma. SAL4 was focally positive. Cytokeratin was patchy positive. Desmin was negative, excluding rhabdomyosarcoma and desmoplastic small round cell tumor. Inhibin was negative, excluding 6-cord stromal origin. HMB45 was negative, excluding malignant melanoma. And CD99 was negative, excluding Ewing sarcoma. So, after excluding all these entities, Sherlock thought of the positivity of SAL4 and the possibility of the germ cell tumor. So, another panel was done. CD117 was negative, excluding dysgerminoma. Glypican was negative, excluding yolk sac tumor.
And try and, yeah, exactly. Just
CD30 was negative, excluding embryonal carcinoma. So, after excluding the germ cell origin, we didn't forget the patchy positivity of cytokeratin. So another panel was done to exclude the possibility of epithelial tumors. EMA was focally positive. PAX8 and BR were negative, excluding epithelial tumors as high-grade serous carcinoma. Synaptophysin was focally weak positive. Napsin A was negative, excluding clear cell carcinoma. P53 was of the wild type. Surprisingly, WT1 and P16 were diffusely positive, and this excluded also the small cell carcinoma pulmonary type. So, after excluding all these carcinomas, we were left with the two main differential diagnoses, small cell carcinoma hypercalcemic type and undifferentiated carcinoma. A final panel was done. INI1 or SMARC-P1 was retained. SMARC-A4 or BRG was lost with a positive internal control. So, after excluding all these entities, can you guess who is our main suspect? Who is the killer of our young lady? So, collecting our evidences, the age of the patient, and the follicle-like spaces with small and large cells, with the immunohistochemical staining, the diffuse positivity of WT1, P16, and the wild-type P53, with the variable expression of EMA, SEL4, and synaptophysin, and the retained INI1 and the loss of BRG, yes, we can conclude that our killer is small cell carcinoma of the ovary of hypercalcemic type and exclude the undifferentiated carcinoma. So, but Sherlock had a little problem here. This photo shows the classic small cell carcinoma where cells are crowded and overlapping with minimal cytoplasm. And this is not our case, where cells are larger with much more abundant cytoplasm. But this wasn't contradicted with our diagnosis, as this case represented the large cell variant of the small cell carcinoma, which is found under the miscellaneous tumor as stated in the WHO ICD coding classification. So, who is our real killer here? Yes, it's small cell carcinoma of the ovary of hypercalcemic type, large cell variant. It's an undifferentiated tumor composed of small cells with or without a large cell component, often associated with hypercalcemia. It's unrelated to the small cell pulmonary carcinoma. If more than 50% of the tumor showed a large cell component, it's referred to as a small cell carcinoma, large cell variant, as in our case. Was first described by Robert Scully in 1978, it's a rare tumor accounting for less than 1% of the ovarian tumors. It almost exclusively occurs in women and children with an average age of 25 years. Most of the patients present with abdominal pain and distension. 2/3 of the patients have paraneoplastic hypercalcemia. Regarding the genetics of our tumor, somatic and germline mutations in SMARC-A4 are detected in almost all cases, and it includes for the SMARC-A4 protein, also called the BRG1, which is one of the enzymatic components of the switch-SNF chromatin remodeling complex, the other being SMARC-A2. The etiology of our tumor, its origin remains unknown. Although it was initially believed to be of an epithelial origin, studies have suggested a germ cell, 6-cord, or neuroendocrine origin, but none was proved. Coming to the immunohistochemical staining of our tumor, it's diffusely positive for the WT1, P16, and P53 of the wild type. Variable expression of SAL4, keratins, EMA, CD10, especially in the large cell component, as in our case. The negative staining includes the loss of nuclear expression of the SMARC-A4 and SMARC-A2 in almost all the cases, with the loss of expression of INI1 staining in the rare cases of SMARC-A4 retained tumors. Calretinin, CD99, inhibin, TTF1, OCT3/4, and FOXL2 are negative. Regarding the WHO essential and desirable criteria of our tumor, it's an undifferentiated tumor, predominantly monomorphic small cells and follicle-like spaces, with or without a large cell component with no association with surface epithelial carcinomas. The desirable criteria include SMARCA4 deficiency. The prognosis of our tumor is poor despite combined surgery and aggressive chemoradiation, with a favorable prognostic factors which include older patient age at diagnosis, normal calcium levels, small tumor size, and absence of large cell component. There is no established treatment for our tumor, but patients are usually treated by a combination of surgery, chemotherapy, and radiation. Our take-home message is that tumors that present with small round cells in the ovary represent a heterogeneous group that needed us to be Sherlock Holmes to correlate clinical, radiological, morphological, and immunohistochemical data in order to reach a final accurate diagnosis and exclude all these mimics. So this is a gift from Sherlock. It's a summary of most of the small round blue cell tumors in the ovary. This is table 1. And this is table 2. These are the references, and thank you.
Thank you so much, Dr. Randa, for such an interesting case and interesting presentation. Thank you so much for your work.
Thank you, Dr. Muhammad.
I would like to present our